Current issues in healthcare, emergency care and crisis. We've all heard the stories: crowded emergency departments in big cities, inadequate care in rural areas, people who use the emergency department for routine health care, security issues, and long waits only to be sent home, or diversion to other hospitals. As the number of people visiting emergency departments has increased, the number of functioning emergency departments has gone down. The CDC cites a 14% decrease since 1993. In addition to this increased patient volume, several other factors contribute to the emergency department crisis. These include increased costs of operation, large number of uninsured individuals using the ER for primary care, patient dumping by other healthcare providers, lower reimbursement rate for many services, and then EMTALA, which is the Federal Emergency Medical Treatment in Active Labor Act of 1986, that guarantees any patient the right to be seen in an emergency room regardless of ability to pay. Finally, lower reimbursement rates and the necessity to prepare for possible natural disasters or acts of terror have added to the burden. All of these factors combined have put stress on providers, physicians, and nurses who staff emergency departments, and others. It's a high-risk job with possible exposure to bloodborne disease, patients who may be mentally unstable and aggressive or even violent, long hours with unpredictable patient load, and the threat of multiple lawsuits. But is this always the case, or is it typical? My last visit to the emergency department went very well. Our next-door neighbor was a first-year medical student. Arkansas Children's is less than a mile away from my house. The wait was minimal, the nurses sweet, the doctor efficient, and the staples something to brag about. Enough blood spill to make for good playground stories, but no concussion or fracture. A late-night adventure that ended with a new Xbox game and ice cream. I've actually not ever had a bad ER experience, but this is not the case for everyone. So, as this cartoon illustrates, that is not the case for everyone. While it's humorous if you just have a broken ankle or need stitches, it's not so funny for people with traumatic injuries like concussions, appendicitis, or heart problems. So how bad is the situation nationwide? Starting in 2006, the American College of Emergency Physicians conducted a national survey of emergency departments in each state. The most recent report card is 2014, and it assesses the emergency care environments of each state and whether government policies are supportive of emergency care in 5 different categories: access to emergency care, quality and patient safety environment, medical liability environment, public health and injury prevention, and disaster preparedness. This map illustrates the 2014 report. In the 2009 report, the ACEP gave the nation as a whole a C-. Only Nevada and Montana received an A-, and there were only a smattering of B's, California and some East Coast states. Unfortunately, at that time, Arkansas fell at the very bottom. As a whole, the nation was downgraded to a D+ in 2014, while Arkansas remained a D-. Bear in mind that this report likely contains data from 18 to 24 months prior to its publication. It may not take into account the changes in the Arkansas trauma system over the last 7 years, and it certainly does not take into account the fact that UAMS and Arkansas Children's Hospitals were designated as the state's only Level 1 trauma centers in 2014, and then 4 other hospitals were designated as Level 2 centers in 2015, plus 1 more in 2016. But even though somewhat dated, empirically based report cards such as this help us to see the big picture and to get a sense of the magnitude of the problem. And the top-ranked states in 2014, including D.C., were D.C., Massachusetts, Maine, Nebraska, and Colorado. The bottom-ranked were, Arkansas was second to last, but had moved up from last place in 2009, and then finishing out the bottom 5 were Kentucky, Montana, New Mexico, and Wyoming. The area in which Arkansas did the worst in 2014 was access to care. The measure of access to care, or access to emergency care, from the ACEP is defined thus. This category measures the availability of emergency care resources such as numbers of emergency physicians, emergency departments, registered nurses, and trauma centers per person, along with proximity to level 1 or 2 trauma centers, and the median time from arrival to departure from the emergency department. Because emergency department capacity is also a function of the broader healthcare system, this access category includes key measures of that whole system's capacity, such as the availability of primary care, mental health care, and substance abuse treatment. It also includes the numbers of available inpatient hospital beds, psychiatric beds, and designated pediatric specialty centers, because greater capacity in those areas can alleviate crowding and boarding within emergency departments. So you see some of the areas that you're looking at in your county health measures also relate to the access to emergency care. Since one of the most commonly cited concerns in emergency departments across the country is the lack of access to on-call specialists, this category also includes measures of the total supply of commonly requested specialists, including neurosurgeons, orthopedists, hand surgeons, plastic surgeons, ear, nose, and throat specialists. As an example of the complexity of the access issue, it should be noted that while the number of specific specialists is measurable, many of these specialists have curtailed their availability for emergency services for any of a number of reasons, including conflicting clinical responsibilities and the cost and risk of medical liability when caring for emergency patients. So, according to its own professional organization, the state of emergency medicine in this country today is in trouble. The category shown here comprises 30% of the grade for each state. There are 4 other categories, including the composite or total score that you saw on the earlier map. The next measure is quality and patient safety. This makes up 20% of the grade. This measure includes also state systems and institutions that help to support emergency care. And we're going to learn a lot more about quality later in the semester. There's a whole chapter on quality, but there are measures to indicate how well an institution is providing quality care to its patients. The medical liability environment makes up another 20% of the grade. Insurance rates for emergency docs are notoriously high, and according to the ACEP, these costs add as much as $108 billion to the total annual cost of health care in this country. Next, public health and injury prevention. Some measures here include traffic safety, drunk driving stats, immunizations, state injury prevention efforts, and so on. The level of this measure adds 15% to the state's overall grade. Here again, I have to stop and point out that Arkansas is working hard and fast to improve all of these, which is not captured in the data presented here yet. The final category is disaster preparedness, which includes coordination, hospital capacity, money, experience, and collaboration. So this is a comparison of Arkansas to the top-ranked state, so to speak, the District of Columbia, on all 5 of the measures for both years, 2009 and 2014. In my mind, this is not a fair comparison because the nation's capital is geographically small, densely populated, and must maintain good access and disaster preparedness at all times because the President and Congress and a lot of other branches of the government are there. But comparing Arkansas to the second highest ranked state, Massachusetts, we can see that we have a long way to go to catch up. I noticed that very few states in the country have a good medical liability environment. The rates that insurance companies charge for medical liability coverage, in addition to driving physicians out of some specialties like obstetrics or on-call specialty services, has resulted in fewer ER docs. Keep in mind that emergency care is going to vary not only across states, but also within states and even within cities. Relative trauma deserts with decreased access to immediate care were found in certain areas of Chicago and adversely affected mortality rates from gunshot wounds. These results may help to inform decisions about trauma systems and funding. So from the this graph is from the American Journal of Public Health in 2013 by Crandall and Associates. This map from the Chicago Tribune illustrates the disproportionate numbers of gunshot wounds that have to drive 10 miles or more to a level 1 trauma center in Chicago. Research has shown that having to drive this far reduces a gunshot victim's chances of survival. So don't just think states and small rural states versus densely populated areas. You would think that Chicago, with its population, would have excellent emergency care, but that is not the case, particularly for residents living in the South Side where the need is greater. It occurred to me as I was researching this material that the ACEP report card could have easily been modeled off the Flexner report of 1910. I hope that you will all read about this in Chapter 3 in the text if you haven't already. Abraham Flexner, who wasn't even a doctor, by the way, was hired by Carnegie Foundation and the American Medical Association to investigate medical schools in this country and make recommendations on reform. The AMA found that over half of the hospitals or half of the medical schools did not provide adequate training. This was the beginning of a long process that resulted in stricter licensing and accreditation requirements. The closure of some hospitals occurred, and the dominance of the American Medical Association as the de facto governing body of the profession was born. In fact, this is always used as an historical example in sociology texts on how professions become established as legitimate in society. The same Abraham Flexner, by the way, stated that social work is not a profession, to which I say humph, but I digress. Given that the ACEP is a professional organization comprised of practitioners themselves, the impact of the report cards they have done that will be issued every 5 years is likely to be significant. One of the first steps in actually changing policy, as we'll learn in the last couple of chapters in this text, is bringing the issue to public awareness so that enough political will and power can be brought to bear to make changes. So unless the public has an awareness of the fact that this is an issue, it's very hard to get any kind of policy passed. The Institute of Medicine has been funded to study the future of emergency department care in the U.S. It's still in the planning and research stages. The ACEP is actively recruiting advocates and has started a letter-writing campaign to state and national representatives and congressmen. The Joint Commission of Accreditation of Healthcare Organizations, also now called JCAHO, also just called the Joint Commission now, has developed a set of emergency preparedness competencies for all hospital employees. JCAHO also has the power to revoke accreditation of hospitals who do not meet a set of standards of emergency care. And I'd like to add here, just as a footnote, that this is how a lot of times health policy is passed without the government's involvement. So if JCAHO says that a hospital is not accredited, it doesn't matter what the state laws are, that hospital is no longer accredited, and then as a result will lose funding and lose patients. At the time of the 2009 ACEP report, Arkansas was the only state in the country without a Level 1 trauma center. Designation as Level 1 means that the hospital has 24-hour coverage, not just with physicians, but general surgeons, orthopedic surgeons, neurosurgeons, and other specialists. ICU monitoring, vascular, thoracic, spine, and burn injury treatment are covered. General surgical residency programs, trauma-related research, and community outreach and injury prevention programs are also required. So it's a lot to get done. Part of the reason to be optimistic about the prospects for Arkansas over the next 5 years dates back to the passage of Arkansas Act 393, the Trauma System Act in 2009. At that time, $25 million was appropriated for the Arkansas Department of Health to implement the system. According to the ADH, based on national data and the experience of other states, it usually takes 7 to 10 years to demonstrate a reduction in morbidity and mortality as the result of a new trauma system. As mentioned before, and as you can see here, both UAMS and Children's now have this designation. The other two nearest Level 1 centers are in Memphis, and then there's another one in Springfield, Missouri. And I wanted to add here that this is the most recent map of the trauma system that I've been able to find. They may be in the process of updating that at the Department of Health. Of course, it takes more than just 2 Level 1 trauma centers to create a working trauma system to improve emergency care across the whole state. Arkansas now has 7 Trauma Regional Advisory Councils, or TRACs, TRACs, which provide expertise and resources to the Department of Health. They are charged with designing and putting into place components of the trauma system. Some activities they do include needs assessments, data collection, quality of care evaluations, and quality improvement. Injury prevention is an important component, as well as pre-hospital acute care. And now that's the care that happens in the ambulance or in the helicopter on the way to the hospital. Both of these are areas where public health professionals, particularly health educators, play important roles. In fact, the trauma system activities have room for employees with skills in all 5 concentrations of public health taught here at UAMS. For example, education and behavior change related to bike and motorcycle helmet safety, surveillance and other epidemiological studies through the trauma registry to identify trends and injuries over time when new policies are implemented, biostatistics for the evaluation of the data on injuries and on the success of prevention methods, health policy and management recommendations regarding best practices, needs for funding, and regulations for patient transport safety, environmental and occupational health for workplace injury prevention and mitigating environmental hazards. All of these activities fall within the purview of the trauma system and its associated TRACs. And this is just a listing of the components of the trauma system as it exists today. So you've got the infrastructure at the Department of Health, you've got EMS, you've got the statewide communication system and call center, and I'm hoping to find a video of that I can post for you to also view this week. Designated trauma centers, and we've got level 1, 2, and 3. The trauma registry, and that can be used for research, epidemiological research, and calculating rates and such. Rehabilitation is part of the trauma system. Quality improvement, injury prevention, and education. I'm going to post a link to the Arkansas Trauma Center in the notes so that you can look at it. You can find the entire national report card on the ACEP website. The Institute of Medicine and the Joint Commission pages will be helpful for getting varied perspectives, and the Arkansas Department of Health's website is an excellent resource for our state. This would be a great topic for a paper, and one of our former students is on the advisory board, so if you would like me to put you in touch with him, you could interview him. In summary, these topics are only the tip of the iceberg when it comes to healthcare system issues for the 21st century. Imagine a physician in the early 1900s trying to anticipate what the next century or half century or even 10 years would bring for health and medical care. With information and issues emerging daily, it can be very difficult to stay current with the industry. Nonetheless, it is an important skill for administrators, policy advocates, and public health professionals to develop. Each person will have his or her own way of doing it. These are just some techniques that I would suggest for the busy professional. Build a reference library, not books, a digital library. I keep a list of the top websites for healthcare issues and add to them as I discover new ones. I don't use my favorite buttons in Explorer for that. I mean, you can do that, or in Chrome or whatever you use. You can do that, but I also keep them as hyperlinks in a Word document, so I can just pull it up and right-click on them anytime I want to. It helps to group them under subheadings such as medical procedures, health economics, statistical data, policy issues, and so on. There are many newsletters that you can subscribe to electronically that will keep you informed. In fact, as you browse through the URLs from this lecture, you may want to see if there are any newsletters there that might interest you. For example, Health Affairs, which is something I'm going to also address in a Twitter feed, but Health Affairs has a newsletter weekly that particularly for you MHA students is going to be very useful going forward. And so finally, Twitter feeds are a great way to get your healthcare news in short bites that keep you informed and give you an idea about which topic you want to read more about. I'm going to put some on the next slide. So if you have any other interesting ones that you want to post in the discussion, that would be great. Just post them in any discussion that you want, because I really think Twitter feeds are the best way to keep current with everything that's going on in science, medicine, and healthcare. That's it for this week.